Welcome friends, this is Dr. Jaitly from New York, your cardiologist on your favorite video site, MuniSTHealth, which is being shown on several social platforms media, mainly to improve the medical education in our medical fraternity, including students, residents, fellows, and of course older colleagues like me, and improving the patient education, because the two of them have been my deepest belief in the past 40 years in my practice, where I've shown that the clinical outcomes are certainly improved, and now it's been shown worldwide. So this has become a global initiative for me through MuniSTHealth. So welcome again to be associated with MuniSTHealth. Without any further ado, I'd like to delve into the subject matter. As I always say, this is not a substitute to the syllabus for my medical students, the dear ones. It's definitely not a medical advice channel either. It's totally informational and educational channel. And 3, if you're having an emergency, experiencing an emergency, please go and see a doctor right away, get to the hospital, call for an ambulance, or if you're in the United States, call 911. So without having done those housekeeping rules aside, now let's do the following. The subject today we're going to be talking about is ASD, which is an atrial septal defect. And how many of them are? There are 3 types. 1, 2. I wrote a little bit earlier, so this way we save time and quickly browse through quickly. So Ostium secundum defect, Ostium primum defect, and sinus venosus. Well, first understand what is an ASD. We know the heart is 4-chambered, okay, as shown being here. So this is your right atrium. This becomes your left atrium. This is your right ventricle, and this is left ventricle. Okay, so the shunt occurs when the shunt it's like a small hole. We've talked about holes in the heart. This is for lay people and general people. Holes in the heart. So basically, this is a hole in the top chambers. It's communication between left atrium and right atrium. Remember, these are ASDs. If they are VSDs, they will be at the bottom chambers. That means the right ventricle and the left ventricle will be communicating here. Normally, the chambers are not communicating. There's a whole entire wall. This is an inter-atrial septum and the interventricular septum. So as the fetus is growing within the mother's womb, what happens is normally there is a flap which is called it's called Fossa ovalis. Fossa ovalis, yes. It's called Fossa ovalis, and that converts into a complete flap. So the flap will normally close here. As a result, this fossa, the blue one, that is the fossa ovalis, that completely closes it. So there is no patent foramen ovale. So normally that is the scenario. However, what happens is there's also a septum secundum growing from the top and a septum primum growing from the bottom. Do not confuse. There are 2 portions of the septum they're growing, and as they're uniting together, they will complete the wall totally. Okay, and there's a third guy called the endocardial cushion here, if you will. So there are 3 things: septum primum on the top, septum secundum, and then the endocardial cushion. We are writing these 3 guys. So all of them, they unite together in order to, and as they're growing, as the fetus is growing, to separate, and therefore the right atrium and left atrium are independently separated, and the wall is fully closed by the time the child is born. Except that patent foramen ovale, which will close the fossa ovalis, right? I've shown here that'll close soon after birth, because that has a whole different purpose as the child is growing, because the lungs are not inflating, because the child is not breathing. He or she, the baby, is actually growing while the circulation is traversing from left to right, and therefore it's going through the whole patent foramen ovale. Which is a boon. Thank God we have the nature's work is at its best here. Now, so septum primum, when it fails to unite with the endocardial cushion, you result into, this is your endocardial cushion, remember, at the bottom, and this is your septum primum, which is growing, and that fails to unite here. That results into this defect, and that defect becomes, what is that defect? That is your ostium primum defect, because that will occur here. So these are the frontal views I've shown. These are your lateral views. So you got lateral and frontal views here. So when you're looking at the heart from the front, it appears like this. When you're looking at the heart from the side, it looks like this. Again, the ventricles are at the bottom here. These are the atrium. You're looking from the side view. So side view and the front view. Okay. Now, having said that, what is this? This is your superior vena cava or inferior vena cava, as the blood is, all deoxygenated blood is arriving into the right atrium, as you know. So when it's arriving here, Now, what if the entire septum primum and septum secundum, it closes fully? So here, in the green, I've shown it closes fully, including the endocardial cushion defects. So all these three, septum primum, secundum, and septum secundum and endocardial cushion, it closes fully, but the superior vena cava or the inferior vena cava, depending upon SVC or IVC, they are malpositioned. So you will have a defect open here. So that becomes a defect, you see? So now it is communicating freely from the left atrium on this side to the right atrium on this side. You get it? So it's a birth defect that's occurring as a result of non-union of some walls within the atrium. In simple terms, I'm just making it simple for the lay person. However, if you have to define exactly what's happening, therefore I've used all these terms. Now, and the first variety, of course, as I said, where the septum primum, which is growing from the top, and the secundum, which is growing from the bottom, septum primum fails to grow and the septum secundum is excessively absorbing. So that's an issue. So all of these are various defects like ostium secundum, ostium primum, and sinus venosus I've defined. Now, what are the clinical features? Well, sometimes it goes totally undetected until the 4th or the 5th decade, when it starts to manifest either as a heart murmur or as a wide fixed sound which will occur. So here is an S1 sound, that's an S2 sound. We know lub dub, lub dub, lub dub. That's how the heart sounds, right? So between the lub dub, there is lub drup, lub drup, lub drup. So that is your split sound, and that split sound is the wide fixed sound, lub drup, lub drop. You see? So the second sound is fixed and it's not varying with the respiration, and that's what is a wide fixed S2. Now, in addition, you may have two murmurs. One is a pulmonary flow murmur, which is an excessive flow. Why? Because now you have a flow which is traversing from left to right, and obviously here's your pulmonary artery, for instance. I'll show you the pulmonary artery here, and as I'm drawing it here, you'll get an idea that ultimately all of that excessive flow, which is not supposed to be coming from left to the right, was only supposed to come from the vena cava, all the deoxygenated blood. Now the oxygenated blood is returning back here. You know, that's an extra work for the pulmonary, for this right ventricle. So the pulmonary circuit will carry more blood. So you have increased pulmonary flow, and so also you'll have increased tricuspid flow, because the tricuspid valve just sits right there and the pulmonary valve sits right there. So you have an increased tricuspid valve flow and you have an increased pulmonary valve flow by definition, and therefore these two murmurs will occur. So pulmonary flow normally occurs in systole, so that's more like a crescendo type of murmur, as you see here. I've drawn it between S1 and S2, and the tricuspid flow is an almost like a mitral stenosis murmur, except it's occurring on the right side. It's called the TS murmur, tricuspid stenosis murmur. So it'll have an early diastolic rumble and then a presystolic accentuation. You see how it's going? Early diastolic rumble and a presystolic accentuation right before the S1 starts. So you have two murmurs: pulmonary flow murmur from an increased flow, and a tricuspid flow, increased flow murmur from tricuspid valve as well. Okay, so these are the two murmurs, and these three will clinch the diagnosis, if you will, if you have a wide fixed sound of the S2 and a pulmonary flow and a tricuspid flow murmur. Echo is, of course, a clincher here, diagnostics, because many times your clinical features may not be totally available, so you look at the echo. Echo will definitely define a left to right shunt. So you'll see a left to right shunt, and in fact the shunt will appear in mosaic colors, so you can see the mosaic colors coming in here, and all these fancy colors will appear, and as a result you will have an increased flow. And of course I got to show you the green color here. It gives you, so this flow that's normally occurring like this will become a left to right shunt here like this, which is normally not present. Okay, so there's no left to right shunt, so there are no shunts. So if it's occurring in the across the inter-atrial septum, that's a clincher. You'll definitely also see the pulmonary flow, which may be increased. You'll see a tricuspid flow that will be increased, and of course the signs of pulmonary hypertension will appear, like maybe there may be increased pressures from RV-SP. Pressures may be high. Normally it should be about 20. Those pressures will be high. You may have pulmonary arterial pressure be high, and all these can be measured by your echo, which is a wonderful technique. By the way, it's a non-radiating technique. It's absolutely safe in an ultrasound, and it's safe in pregnancy also. So what is the treatment quickly? There are 3 devices, because obviously you have to close surgically, and Amplatzer device has been there forever, and ever since my student days. So this has been around and it's been improvised, etc. So these are great devices. They are like basically 2 discs. One disc goes on this side, the other disc goes on that side, and just close the so basically it just closes the defect right here. If I close the disc here, I'll show you exactly how the disc will look like here. So these 2 can be closed, and therefore this defect can be fully closed. Helix device is the second one, which is like an umbrella. So it has its cords, it has 4 arms to it, and there'll be 2 sets of umbrellas. They'll just go in and fit in the same way, just like an Amplatzer device, more or less. It's an umbrella. It's a folding umbrella, and they're all done percutaneously, so through a catheter. And a cardioseptal device. Of course, I'm not a surgeon, but there is another cardioseptal device which is normally reserved for ventricle VSDs, or ventricle septal defects, but it can be used also for atrial. Okay, so in a nutshell, it's basically a hole in the heart, which is mostly between the top 2 chambers, because of failure to close completely those walls, normally during the time of the fetal growth. And it's a congenital abnormality. Normally it is very livable with life, if you will, if there's a word, and until about 4th or 5th decade, when things can manifest in terms of a white fixed second sound, or certain murmurs that will appear. And then of course an echo will reveal sometimes an incidental echo that could be done, which will show a left to right shunt, because that will be diagnostic across the inter-atrial septum, and increased flows of pulmonary and tricuspid nature, and sometimes signs of pulmonary hypertension. A T is normally not required unless and until really you have to document the size of the defect, and of course the flow that you have to demonstrate before the device is being placed in. But sometimes echo is sufficient to really give you enough both in the lateral view as well as in the frontal view, exactly how big the defect is, what the nature of the flow is, what the volume of the flow is that's occurring, etc., etc. Okay, so again, a hole in the heart in the top 2 chambers, between the top 2 chambers, from a failure of growth of the entire wall. That's called atrial septal defect. Again, once again, my deepest belief is medical education and patient education together be combined, so the clinical outcomes can be the best. And when you go and discuss all of this with your physician, with your cardiologist, you'll be in a better footing to really make sense out of what the discussion goes through. Okay, wonderful. And of course, feel free to like the button, and of course subscribe to it. Do not forget to click on the subscribe button as well, because we are here to only educate you to the fullest. Okay, thanks again, and do write your suggestions, your comments, and I'll make it a point to answer within 24 hours. Thanks, and stay well, and stay on MuniSTHealth.